My name's Dr. Thida Thant, and I'm a CL psychiatrist from the University of Colorado School of Medicine. And I'm super excited today to come talk to you about this very fun topic of cannabis, from euphoria to encephalopathy, updates on the neuropsychiatric effects of cannabis. So no exciting disclosures today. And I'm hoping by the end of this updates course, you'll feel like a couple things are true, that you'll be able to identify the physical health effects of cannabis use, such as cardiovascular complications, lung injury, cannabinoid hyperemesis, that you'll feel confident discussing the neuropsychiatric effects of cannabis use, such as use disorders, withdrawal, mood changes, psychosis, catatonia, and delirium. And lastly, that you'll feel like you're able to evaluate the potential risks and benefits of cannabis in psychiatric patients and develop a practical framework for approaching risk-benefit discussions with other healthcare providers. So why does this topic matter? I think if you're watching this recording, you already know why it matters, right? It's controversial and provocative, but there are really more and more states with legalization or liberalization laws, if you want to call it that. Cannabis remains the most commonly used federally illegal drug in the US, despite kind of a different legal status at the state level. And also, really just it feels like everybody's using it, especially if you're in a state where it's legal. And so you can see here over the last few years, it's been a sharp uptick in the prevalence of almost everything: daily and near daily use, days of use per capita, past month prevalence, and past year prevalence. So I'm going to do this in the form of a case and interweave some things in, hopefully so you feel like you know how to apply this information when something comes up on consults. So we'll start with a 60-year-old gentleman, no known psychiatric or medical history, who was brought in by ambulance and admitted to the hospital medicine service for altered mental status after a family member found him confused in his home. Psychiatry was consulted as the patient is saying odd things, acting strangely, and has remained or continued to have altered mental status of unclear origin for the past 4 days. The evaluation when you go in to see him is notable for emotional lability, inattentiveness, fluctuating alertness, and intermittent sedation. He mumbles something about smoking, then falls back asleep. So as you continue to look at his case, you notice there's some tachycardia on exam and mildly elevated blood pressure. His physical exam is notable for ataxia, nystagmus, and slurred speech. And his lab results are most notable for positive drug screen for cannabis and mild, non-specific elevation of LFTs or liver function tests. You get collateral from family because he can't give you much information, and they report a history of seizures, anxiety, chronic pain, cyclic vomiting, and PTSD. They deny any known psychosis, mania, suicide attempts, or psychiatric hospitalizations. They do believe that the only medication he's taking is Depakote or divalproic sodium, which was recently increased. And as far as they know, cannabis is the only substance that the patient uses. A few days later, you round on him and you find him awake. Now you know that his name is Derek. He's awake, less confused, but irritable. He keeps asking about leaving the hospital, and when you talk to nursing, they mention that he keeps mentioning dabbing, and they worry about increasing agitation that hasn't gotten better. So a good place to stop and talk about, or rather, this is a good place to stop and talk about the effect cannabis has on sort of the brain. So first of all, there are reports, mostly at the case report level, of association between cannabis use and altered mental status or delirium, including in the inpatient or acute care medical setting. It's what you would expect. The case reports kind of report inattention, affective lability, dysregulated behavior, intermixed with lethargy, hallucination, slurred speech, ataxia. So, at this point, you might be like, okay, those symptoms sound familiar and like something Derek had. The case reports sadly range all the way from 7 months old up to over 80-year-old, and is often affiliated with kind of unintentional exposure to cannabis. So like eating a baked good found on the counter or getting into kind of a bag of purchases from a dispensary. In this setting, cannabis has been found to impair attention, processing speed, impairs memory, kind of in a lot of domains: episodic, working and verbal memory, learning, executive functioning, and things like reflex time. And also has been associated with mood changes, anxiety, paranoia, and agitation. And when it comes to agitation, there's a lot of different neurotransmitters involved, including the endocannabinoid system, which I will talk about soon. And it's thought that maybe this is kind of multifactorial in nature. There's cannabis, or particularly THC's impact on psychosis, mood, cognition, impulsivity, but also there appears to be this kind of dose-response relationship, low doses being less associated with agitation and higher potency forms of cannabis being associated with increased rates of agitation. So going back to Derek, he tells you that his cannabis use has been steadily increasing for about the last month, from daily to multiple times a day. But honestly, he's been using off and on for the last 10 years. He often dabs or uses high potency forms while also vapes CBD. And he uses both sativa and indica blends, usually because he's having issues with sleep, anxiety, and nausea. So if you're in the audience being like, I don't know what a lot of those words means, don't worry, I'm going to get to that. But for many of us, we have heard patients use these terms. He also reports that nausea and vomiting has been steadily worsening over the last few months, which is why he increases cannabis use. And again, he kind of confirms the history he got from family about Depakote being a medication he's taking for seizures. So some basics in case you're pretty new to this topic. There are tons of cannabinoids in cannabis plants and tons of various compounds. But really clinically right now, especially as psychiatrists, we mostly focus on THC or CBD. THC is the cannabinoid most classically psychoactive, most associated with a lot of side effects that we see or we worry about in the mental health field. And it's a partial agonist of the CB1 receptors. The other key cannabinoid is cannabidiol, or CBD. And as long as you don't have other contaminants like THC, it really should not produce, significant euphoria or intoxication compared to THC. It has a lower affinity for the receptors that I mentioned with THC, but has a lot of interesting kind of mechanisms like negatively modulating or indirectly activating some of the cannabinoid receptors and has some interaction with the serotonin receptors. So I like to bring this up because as you're navigating conversations with patients or as you're looking into this topic, it's helpful to think about like why cannabis has the effects that it has, why do patients find it so helpful and things like that. And so there is the endocannabinoid system. Those of you who know this topic realize this is a very bare bones slide. There's not enough time today for us to kind of do a deep dive into this, but it's good for you to know that there is an endocannabinoid system. Oftentimes kind of bud tenders in dispensaries or patients who are really into cannabis will kind of cite this as a reason why cannabis is not a big deal, that there exists this natural system in the human body with these main endocannabinoids listed here, and that it's natural. And cannabis is natural. This is something the body's producing anyway. And so it's good to understand that this system exists. It does interact with a lot of different things like neural development and things like that. But really, the endogenous cannabinoids, the endocannabinoids like anandamide and 2-AG, do not sort of interact with the cannabinoid receptors the way that exogenous cannabinoids do. That being said, when you look at the CB1 and CB2 receptors that I mentioned earlier and where they're located, you can be like, oh, here's why cannabis has some of the effects that it does. So the CB1 receptors, which I mentioned for both THC and CBD, they're mostly concentrated in places like central nervous system, like basal ganglia, cerebellum, hippocampus, association cortices, spinal cord, etc. And you'll see later when I talk about side effects, where those are coming from. The CB2 receptors, which I talked about a bit more as CBD, they are mostly in the immune system, which for those of us working with immunocompromised patients may cause pause, but I'll talk about that later as well. So earlier, Derek was telling us that he uses both sativa and indica cannabis products. And for some of us, we're like, I don't know what that means. I don't know how to tell what my patient's using. I don't know how to tell the difference between all these different formulations available through cannabis dispensaries. And so a short and quick kind of dirty guide to this is sativa got kind of a higher THC ratio compared to indica, which is a little bit more CBD oriented. And so sativa is supposed to have a bit more of those psychoactive effects, mood altering effects, higher risk of psychosis. And people will talk about using it for things like energy, attention, creativity, kind of things like that. Indica is, like I said, more of a CBD blend. And so it's supposed to give more of this like body high versus the cerebral high sativa. And so it's supposed to help people feel less anxious, help with pain, help with sleep. And so sometimes you can remember by thinking of it as indicouch. So this makes patients feel more comfortable, relaxing and things like that. There are a lot of different kind of routes of administration and formulations available out there. Depending on what state you practice in, you may be very familiar with these. Really, I think most patients will come in talking about like kind of smoking flower, which means sort of the basic plant-based material versus dabbing, which is this upper right-hand corner. They might call that shatter, wax, things like that. And these are really highly concentrated forms that are much more associated with kind of adverse psychiatric effects. Then there's things like edibles, which can be more THC-based, CBD-based, same thing with tinctures, and then topicals, which are sort of the least risky way to use cannabis products. So when it comes to potency, one of the things I want you to take away is that high potency cannabis is kind of no good. That's one of the few strong statements I'll make today. There's really no medical evidence for kind of these concentrates, they're usually heavily THC based. The risk generally outweighs the benefits, and there can be both physical harm from the flammability of the product or making the product, as well as it just being much more associated with things like self-mutilation, acute psychosis, violence, agitation, and things like that. And really, again, not a lot of medical evidence for even things like pain, etc. So when it comes to basal pharmacokinetics, again, many of you may be kind of anecdotally familiar with this, but we really think about kind of smoked forms versus like orally ingested forms, right? And so the easy way to think about it is when you smoke it, you have a kind of peak, you hit the peak faster, onset of action is faster, and it wears off faster, unlike orally ingested forms, which take much longer to hit peak plasma levels. And so if someone kind of overshoots, so to speak, with orally ingested or edible forms of cannabis, they're in for a much longer ride than someone who overshoots with smoking. So this is something we see a lot with medical tourism in places like Colorado, where people come in, they're not used to the potency, they're not used to like the dosing even. Like if you buy a cookie, most people will think a serving size is the cookie, but in many places it might be a tenth of a cookie. And so people frequently kind of overdose with cannabis. The other things to know is that estimated bioavailability between the two forms is pretty similar. With the smoked version, you lose a lot of it in the actual combustion process, versus with the orally ingested, you have both gastric degradation and then first pass metabolism by the liver, which I know many patients don't think about. This slide I know is crazy. I'll probably include this table as a handout, but I want that shock factor there because I want you to see that when it comes to marijuana or cannabis and medication interactions, there are a lot. Cannabis is, I mentioned, right, metabolized through the liver. The CYP system has something to do with it. And so all the other medications that go through the cytochrome system are impacted. And that's a lot of our medications, right? Or a lot of other things that our medically complex patients are on. Generally, cannabis seems to elevate levels of other medications, and though in and of itself won't cause life-threatening sedation or respiratory depression, is synergistic when mixed with alcohol and other CNS depressants. So, might just be the final straw that kind of tips things over. This slide is really based on the pharmaceutical cannabinoid Epidiolex, which the generic is cannabidiol, because actually Epidiolex is one of the only plant-based pharmaceutical cannabinoids or cannabis products that we have. And so it's actually purified plant material. And so it's been very helpful for having some insight into like, what do we need to worry about if a patient comes in saying, don't worry, I just use CBD, I don't really use THC. So again, you can see the cytochrome system plays a role here. But what I highlighted in gold is what's, I think, really relevant to those in the mental health field. It does interact with a lot of anti-epileptic medications, and it elevates levels of medications like clobazam. And when it's administered with things like valproic acid, it increases the risk for LFT elevation. So thinking back to Derek or, our patient, you're like, oh, what's kind of going on there, right? Because when he came in, he had mild LFT elevation. When you combine with other CNS depressants, like I said in the last slide, you may have increased somnolence. And there have been some case reports about things like interactions with warfarin requiring warfarin adjustment to stay, within goal range and things like that. So it's not super benign. It does have potential impacts from a pharmacology standpoint and potential impacts for things like liver, LFT monitoring. So, and actually one thing I didn't mention on this slide real quick is that actually with cannabidiol, Epidiolex, I'll mention it again later, you do actually have to monitor LFTs, which is something most of us are not doing with our patients that use cannabis. So going back to our case, since waking up in the hospital, Derek says he's been having a lot of nausea, vomiting, decreased appetite, tremor, vivid dreams, disrupted sleep, cannabis cravings, and irritability. So a lot of stuff, right? And the medical team knows that he's been taking really long, hot showers every day for nausea. While you're interviewing him, he denies hallucinations, but towards the end, he kind of says, I need to get out of here. I don't feel safe here. And you're like, I wonder what that's about. So when you ask him more questions, he says, it feels like the staff are always talking about me. I can hear them through the air ducts, and he feels like he's being watched. So you're like, ooh, maybe he's not having hallucinations, but I am concerned about psychosis. So a couple of things I want to pause and talk about here. So when you're working with patients in kind of any setting, but particularly in the medical setting, when they have a significant history of cannabis use, you want to pay attention to things like cannabis intoxication and cannabis withdrawal. For most of us in the acute medical setting, we're not going to encounter someone with cannabis intoxication. That usually is seen more in like ED settings and things like that. Or if your patient happened to bring in some things from home, that could happen. But on average, we're more likely to actually encounter withdrawal, though many of us do not screen for this. So cannabis intoxication, again, I think many of us are very familiar with it, right? It has to have recent use, not just a positive urine drug screen. It should be associated with sort of behavioral, psychological changes, things like impaired motor coordination, changes in mood, things like that. And then 2 or more of the following, right? Got kind of red eyes, increased appetite, dry mouth, tachycardia. When it comes to cannabis withdrawal, it really is not seen with someone who like has used it like once or twice. This is really seen in our patients who have heavy and prolonged cannabis use, usually daily or almost daily over a period of at least a few months, if not longer. And they need to have 3 or more of the following signs within 1 week of stopping or significantly cutting down their cannabis use. So they'll see irritability, anger or aggression, nervousness or anxiety, sleep issues, usually insomnia or disturbing dreams, changes in appetite or weight loss, restlessness, depressed mood, at least one of the following physical symptoms. So abdominal pain, shakiness or tremors, sweating, fever, chills, or headache. So many of you might be surprised to hear that withdrawing from cannabis can cause these kind of issues. And so when it comes to withdrawal, of course, it's kind of like alcohol, actually. So onset's usually within 24 to 72 hours of cessation. It peaks within the first week, and then it usually lasts 1 or 2 weeks. But for some patients, if you think about how cannabis is lipophilic and depending on how long they've been using, it can take a really long time for this to come out of their system. And so they may have things like sleep difficulties for up to 30 plus days in sort of a post-acute withdrawal kind of picture. And actually, though many patients don't believe you can have a use disorder or withdrawal related to cannabis, up to a third of regular cannabis users report experiencing cannabis withdrawal. So that's just the folks who report it, right? The rates are probably higher. And this is even higher when you look at patients who are in active kind of use, like substance use disorder treatment and things like that. In those settings, 50 to 95% will report symptoms of cannabis withdrawal. So now you might be like, okay, maybe I have been screening, or maybe like now you feel like you are going to screen for cannabis withdrawal, right? So what do you do about it? So when it comes to mild withdrawal, not a lot that you need to do necessarily. Some patients benefit for things like CBT if they're having kind of mood or anxiety symptoms, but things like exercise, meditation, prayer, over-the-counter analgesics may do the trick. They may need some help with sleep medications or something like that. But most of us are going to be worrying about this other category, are folks with moderate to severe withdrawal symptoms who are having a lot of impairment from this. In the acute medical setting, this can manifest as acute agitation and request to leave AMA. And so there can be different options depending on whether the patient ultimately needs to have a negative urine drug screen or whether it doesn't matter. So this might depend on whether they are on probation or parole. So if you're trying to help someone with cannabis withdrawal and you're trying to work towards a negative detox, then you might want to use something like gabapentin. I'll talk a bit more about that. If it really doesn't matter, actually most of the evidence and the most efficacy based on my clinical experience is using pharmaceutical cannabinoids. So things like dronabinol, also known as Marinol or nabiximols. If those aren't available or there's a reason you don't want to use those, then again, you can think about gabapentin. But if it's really predominant withdrawal, sleep kind of symptom and withdrawal, UpToDate actually recommends zolpidem. I end up using a lot of other alternatives like trazodone or tazepine, things like that, just given other comorbidities that the patient may have. But if you're looking at using dronabinol, then usually it's actually pretty hefty doses, anywhere from 30 to 90 milligrams per day in divided doses. At my institution, our burn unit actually kind of proactively starts patients on dronabinol to try to minimize things like withdrawal because this comes up a lot in their unit and they get a lot of patients who have a hard time staying in the hospital for care. So the other thing when we were interviewing Derek is he kind of made that mention at the end, right? He's like, people are watching me. I can hear them talking about me. And so cannabis-induced psychosis is definitely a thing. And treatment's like pretty standard, right? Goal is to try to get patient to cut down or stop use. And you would expect that the psychosis should improve over time as long as they abstain from cannabis. But some patients may benefit from an antipsychotic if they either continue to relapse with cannabis or their symptoms are pretty disruptive. And so usually we're using atypical antipsychotics. If symptoms are more refractory, then you can think about other adjunctive treatments such as antiepileptics. But actually, I know many of us don't necessarily want to use these medications long term, but for some folks, it may be a form of harm reduction if they continue to use cannabis or kind of go on and off cannabis or have symptoms that are slower to clear. And this should be used, of course, in addition to psychosocial interventions, motivational interviewing, and other kind of good co-occurring care. So going back to Derek, now we're going to shift to outpatient because I know many of you in the audience may not work in inpatient settings or may not work exclusively in inpatient settings. And so Derek continues to improve with pretty minimal intervention and actually follows up with you in clinic about a month later. At that time, he no longer dabs, which is great, and has decreased his use of flower down to a few times a week. His seizures remain difficult to control, and his neurologist has sort of mentioned cannabis to him, not to mention what all his friends and family have mentioned. He's now wondering if he should re-increase his use or go back to dabbing, because he's like, would that help with my seizures? Would that help with these other things? So I think something else I like to highlight is the role of the psychiatrist, right? So what is our role, especially if there's other providers or other specialties involved that may be talking about cannabis-based products, or, when our patients talk to bud tenders, which is where they get most of their medical information about cannabis as opposed to the medical system, they might be hearing that it's helpful for a lot of things. So it boils down to a few main areas that we do anyway. One, as a psychiatrist, we should identify relevant psychiatric diagnoses and concerns. Things like, is there the presence of a mood disorder or anxiety or psychosis? Do we think there's actually a cannabis use disorder or other kind of concerning substance use? We need to feel equipped to provide psychoeducation on potential adverse effects of cannabis because patients really don't hear about this a lot. And I'm going to go more in depth into potential adverse effects, but we've already covered a lot of them, right, in the case so far. You also need to come up with a way to monitor for the development of a cannabis use disorder or concern for cannabis dependence, right? Like how in your current practice do you screen for this and what kind of labs do you use? And really, if there are other specialties providers kind of throwing this around willy-nilly, because many are like, well, I've heard that it could be helpful for headaches. That might be true, but for your particular patient, that may or may not be a concern. The risks of cannabis use may or may not be worth it. So you have to help these other specialties compare the risk and benefit of cannabis for their quote unquote, their disease or symptom compared to the risk and benefit of cannabis in the setting of your patient's mental health concerns. And then, like I mentioned earlier, you need to be able to monitor for relevant drug-drug interactions and use. So basic framework, right? In your appointment with these patients, again, do what you do best. Do diagnostic evaluation, take a look at their med list, look for any drug-drug interactions, and it's helpful to start to understand at least the current evidence base for therapeutic benefit versus harm of cannabis use in the context of those comorbidities. I don't have enough time in today's session to cover all of those in depth. I will put a shameless plug in. I do have a workshop that's also pre-recorded for ACLP this year where we do talk a bit more about potential therapeutic benefits in specific kind of medical conditions. You also, again, want to then maybe call up or message the other medical provider to be like, hey, can you help me better understand what medical conditions you're considering cannabis for? Did you actually recommend cannabis for this? And let's talk through really the kind of current evidence base for that versus what are my concerns about my patient and what the current evidence base is or is not in existence for their psychiatric comorbidities. So I promised I would do a little bit more about the adverse effects. Again, many of us are pretty familiar with the short-term or acute adverse effects of cannabis use, right? So impaired short-term memory, ability to learn, impaired motor coordination, altered judgment, paranoia, psychosis, euphoria, and then the immunosuppression I alluded to earlier, right, with the CB2 receptors. Then when you start moving more into the long-term or heavy cannabis use, the risks change. There is more of a risk of addiction. There's at least some studies previously said around 9% of overall users, 17% of folks who began using in adolescence, and anywhere from 25 to 50% of folks who are using daily. Don't forget withdrawal, right, as part of addiction. Then depending on how you use it, there can be things like chronic bronchitis symptoms. That really applies if you're smoking it, right? If you're using topical or orally ingesting, that doesn't apply. Cardiac effects apply kind of broadly, though there's increasing concerns. I'll mention this on another slide about the cardiac effects. And then one of the things we do know from a psychiatric perspective is there's definitely an increased risk of developing a chronic psychotic disorder. including schizophrenia in folks who use cannabis heavily and probably also have kind of genetic predisposition. Then there can be sexual side effects. This is actually things like impotence, problems with ejaculation. We usually see this increasingly with like vaping and higher potency forms. And then I'm not a child and adolescent psychiatrist, I'm an adult psychiatrist, but we know that the risk for a lot of things is definitely higher in our child and adolescent population compared to our adult population. So if you are a child and adolescent person listening to me today, and you're sitting here going like, I don't know that she's pushing the risk hard enough. Like you are right. If you are working in the child and adolescent forum, you need to be much more aggressive with trying to decrease use and counsel on the risk of use. But in our younger patients, altered brain development, poor educational outcomes, cognitive impairment, and things like that are relevant, as well as cardiovascular effects like tachycardia and postural hypotension, which might be relevant with the increasing rates of things like POTS, right, in our younger folks, and then things like decreased sperm counts. So I boil down, in my own institution, I have like a 4-hour course on cannabis, and like 1 hour is dedicated essentially to the basics and the literature base for each of these like categories of disorders. Here I boil it down to a single table. So I hope you find this helpful. It's from a book that I edited, but basically I have risk of onset, worsening of course, and whether it's useful for treatment. You can see kind of across the board that for all these conditions, useful for treatment is generally a thumbs down, but it's a more mixed when it comes to depressive and anxiety disorders. When it comes to worsening, of course, pretty clear evidence in things like bipolar disorders. There's some association with like increased hospitalization rates, increased rates of mania, PTSD, and then psychosis. A little bit messier when it comes to things like depression and anxiety. With risk of onset, it's pretty messy as well. We have a hard time knowing with some of the studies if it's sort of like the self-medication effect where someone was already experiencing a mental health condition before they started using cannabis. But it's been associated with risk of onset of quite a few things. So another kind of broad strokes overview table is about the therapeutic use of medical cannabis in neurologic disease. And so you can see here, oops, let me go back, that it's really got the most evidence for kind of seizure-related disorders and maybe some conditions that tend to have like spasticity and pain. Otherwise, pretty mixed for a lot of other things, including dementia, which I know many of us work with. So other health effects, just to be aware, again, you could do deep dives on all of these, but just kind of a quick primer for you all. I mentioned that there's been increased attention paid to cardiac events. So actually the American Academy of Cardiology and all these, they have put out papers fairly recently talking about that we need to be concerned about the cardiac effects of cannabis. It's been associated with, I already mentioned tachycardia, but also stroke, sudden cardiac death, heart attacks, cardiomyopathy, all sorts of stuff, tachyarrhythmias, which we care, we would care about. When it comes to kind of respiratory impact, again, this mostly matters if you are smoking or vaping cannabis, but some of these are kind of old. So if you look at things like fungal infections, that's a bit more in places where maybe you're buying off the quote unquote black market. So when I was in Texas as a medical student, this was a bigger deal. The risk of fungal infections, especially in immunocompromised patient populations like oncologic or HIV. But of course, you can have things like COPD, pneumonias, kind of things like that. And then many of you may remember that in the early 2020s, there was like EVALI, so kind of the vaping associated lung injury that swept the nation. It was like a big deal in younger patients. And this mostly had to do with the vitamin E acetate that was seen in sort of the cannabis cartridges, which were more often sort of off-market creations as opposed to being bought from stores. Cannabinoid hyperemesis syndrome, I bet a lot of you are seeing this, right? So back in 2015, there was a publication that reported approximate doubling of cyclic vomiting syndrome cases in Colorado after marijuana, cannabis was first kind of liberalized or kind of expanded in 2009. If you haven't seen or you're less familiar, it's characterized by chronic cannabis use, cyclic episodes of nausea, vomiting, and frequent hot bathing. And it's sort of part of this umbrella of cyclic vomiting, but you can have other etiologies of cyclic vomiting besides cannabis. So don't assume that someone with cyclic vomiting automatically has cannabis use, but certainly many of them do. The actual mechanism is pretty complicated, but there's 3 main phases: prodromal, hyperemetic, and recovery. Many of us in inpatient CL settings are working with patients during this hyperemetic and recovery period. So where they need a lot, like they might get admitted for IV fluids, IV Zofran, or other antiemetic medications. And it's associated with frequent hot bathing as one of the only helpful intervention. So I mentioned, right, that Derek was spending a lot of time showering, right? The medicine team mentioned that to you. I also mentioned that at least with like some of the studies we have from cannabidiol, the pharmaceutical cannabidiol known as Epidiolex, that there were concerns with liver, right? That there's concerns for elevated LFTs was something noted in the trials related to this medication. And this also even before this, their daily cannabis smoking had been considered predictor for things like fibrosis risks, steatosis severity. So this is especially a bigger deal in your patients that already have maybe liver injury or disease of some sort. And then lastly, I kind of mentioned a couple different times immunosuppression. There's sort of this maybe more hypothetical increased risk of infection. There have been some reports of effects on immunosuppressant levels. So there was a case of increased tacrolimus toxicity, as if that medication needs assistance having more toxicity, potential for increasing cyclosporin blood concentration and toxic effects, and then increased risk of head and neck cancers. A lot of this maybe is like, is that due to the smoking, things like that. So I'm throwing a lot of information at you, but if you think about your basic framework when you're working with these patients, first I said about do a good diagnostic evaluation, assess them for psychiatric comorbidities, assess them for the presence of a use disorder, and assess them for like what is the true refractory nature of the medical symptom that they're considering or reporting using cannabis for. After you do all that, you may be like, well, okay, maybe in this case, one, either the patient isn't going to stop and there's nothing you can do about it, or you might be like, okay, maybe it is sort of questionable. Maybe there is more of this potential therapeutic benefit that warrants the patient, or at least warrants me not constantly talking about them cutting down their cannabis use. If you do that, if you land on that, then you need to focus on safe use and harm reduction. So things like their formulation, right? So Derek was talking about kind of smoking flower versus using dabbing or doing higher potency. There is higher neuropsychiatric risk with higher potency forms. That's something that's good to know. And higher potency forms are not necessarily seen as more effective for medical and neurologic indications. And there have been some studies that for things like pain, that there's actually this dose window. If you go below or above it, then pain can actually be worse or is at least not better with the use of cannabis. Route of use may matter, right? So you may be trying to get them to change from smoking all the time or dabbing to using tinctures or edibles or topical forms when possible, especially if they have things like concurrent respiratory disease, things like that. More frequent use is more associated with use disorders. So try to get your patients to use as infrequently as possible. So like maybe not 4 or 5 times a day, maybe mostly at night, right? Would be a harm reduction approach. And then just good to know things like impact of diet. So high-fat meals could actually significantly increase oral cannabinoid absorption and worsen side effects. So if a patient comes to you being like, oh, I'm having all these symptoms, and they may find themselves increasing their cannabis use to target that, but by doing that, they're actually making things worse. And when they maybe actually need to adjust diet. Earlier, when I was talking about Derek's case, right, I mentioned that he said he was like trying to use it to treat nausea. So if you think about cannabinoid hyperemesis syndrome, it's funny because it's associated with like higher potency and higher cannabis use, but patients, because they see cannabis as helpful for nausea, vomiting, they will increase. So they find themselves caught in this cycle. That's really terrible. And then after you kind of do all the psychoeducation, you have to develop a collaborative plan for monitoring and communication. So I mentioned this earlier, right? And so the role of the psychiatrist. So how will you, in moving forward, determine benefit versus harm? That might be a good time to use things like measurement assisted care, various types of monitoring. So you can kind of keep an eye on like how much are they really using in the future versus now. If things change and now harm is greater than benefit, or for whatever reason patient would like to taper, then you might want to work with the patient or the other team with how to manage that, how to manage withdrawal management, because patients will often try to cold turkey and they'll be like, why do I feel terrible? And then they'll say, see, this is why I need to not stop cannabis. I feel worse off of it. Not really fully understanding that it's really this untreated withdrawal. So I had mentioned kind of monitoring. So, right, most of us use urine drug screens. You need to know what your urine drug screen is actually testing, and most commonly test THC carboxylic acid, which is a non-psychoactive metabolite. You can see this image, it's this red line. So it's this non-psychoactive metabolite that lasts much longer at elevated levels compared to concentrations of actual THC and things like that. So that's just something to know about, right? Because having a positive standard urine drug screen does not directly correlate to things like intoxication or negative, impact or risk. The detection window varies widely depending on frequency, duration of use. Again, it's lipophilic. So if the patient has more body fat, it'll store even more. If they use heavily, we find that they can test positive much longer versus folks who have only used once or twice or use very infrequently. So this is more important for those of you who work in outpatient settings. If you are actually wanting to monitor your patient's use, you can't really just use a urine quant THC level or a standard urine drug screen. You need to kind of use this ratio. And so basically, if you're using urine quant levels, those levels can fluctuate, right, with creatinine, kidney functioning, and levels of hydration. So I work, like I said, I work in Colorado. My patients are always outside, hiking, doing whatever, getting all dehydrated. And so that can really impact, right, the trends of their THC quant on their urine. So what you want to do is actually measure urine creatinine and urine THC quants, or the quantitative level, on the same urine sample, and then trend that ratio. And that should, if they really are kind of decreasing their use over time, that should show after a while. They are maintaining the use, it should not increase as long as you're tracking that ratio. This is a send out, at least in my institution. That's why I said this is more useful for those of us in outpatient or integrated care settings, as opposed to inpatient CL. So I've gone on for a lot of slides. So back to Derek. A few months later, he's been readmitted for altered mental status again. And this time, when you go see him, the evaluation is notable for mutism, echolalia, upper extremity rigidity, and decreased PO intake for several days. Right? So you should be thinking, hopefully you're thinking catatonia. And as I mentioned earlier in this presentation, that is a known potential outcome of using cannabis, especially higher potency cannabis. So after you treat Derek with lorazepam for a few days, he's back to baseline and gets discharged. So, all right, I mentioned this, right? It's really at the case report level, but I think many of us can say we've seen this a lot. And again, I often have seen it with like the synthetics or the high potency forms. But the studies of this go way back. Like look at the dates of these references, and they show this kind of in mouse and rat models as well, that it kind of caused this sort of motoric kind of catatonia. And many patients, when they stop using, their catatonia will improve, and then when they use again, they have a recurrence of catatonia. So Derek follows back up with you outpatient, and he says, I'm back to dabbing, doc. I'm back to using high potency. And he asks you what he should do because, again, his outpatient neurologist has been thinking about cannabidiol, the pharmaceutical form, so Epidiolex, for his seizures. He's also been talking to his family who wonder if he has ADHD and should start medications for that. So for those of you, the outpatient setting, you're probably groaning right now, right? Because this is your life. All day, every day, everyone wants to know about ADHD. And for many of us in states with kind of legalized cannabis, they're all using cannabis. So what do we know about the neurocognitive effects of cannabis across the lifespan? We know that it has negative impacts on cognition. That's the bottom line. I know there's a lot of text here. I have the key findings outlined in red. But right, the folks who are using cannabis, they perform worse on learning, on processing speed, delayed memory, working memory, attention. I already talked about this earlier in the slides, right? And especially in our younger patients, here at the bottom, you can see there is real neurologic impact of using earlier in life. For older patients, it might be, they will have these effects, but it's a little bit less about neural development. So I'm mostly including this for those of us that do outpatient work because I get asked about this all the time. I've been giving talks at APA and stuff, and I get asked about this. So it can feel really hard. What do I do if someone comes in, they're using cannabis every day, but they also want to be evaluated for ADHD? I have lots of psychiatrists telling me that they tell the patient that they cannot diagnose them with ADHD until they completely stop cannabis use. And for some patients, that may be appropriate, but I want to kind of point out that may not make sense for your patient. So we know that when ADHD is left untreated, there's increased risk of negative outcomes like functioning, performance, multiple domains of life, and things like substance use, right? So increased rates of things like cannabis and other substances and a harder time stopping that. And so it might be, if you really, if a person really has the right history, you might end up wanting to treat both concurrently, the cannabis use and their ADHD. When closely monitored, psychostimulants and other adjunctive medications for ADHD or mood or anxiety can be safely used to treat these conditions in patients who use cannabis and improve outcomes related to their cannabis or other substance use. So one thing I always say is try to remember ADHD is a developmental disorder, right? So symptoms should, unless they started their cannabis use very early in life, should predate cannabis use, even if they were able to adequately compensate or things like that. And certainly the cannabis may be worsening or mimicking some symptoms. So I still do talk to patients about that, like, hey, look, we're going to start monitoring your use using this urine, drug screen ratio. And I am willing to maybe start a medication for you, But hey, if it seems like all the meds never seem to work, we probably need to revisit your cannabis use. Or I may tell them, I am expecting that your cannabis use should go down, and we will be monitoring that, and that'll be an expectation as part of care. But it allows them to get, if they have ADHD, to actually get that treatment. This is a screenshot of the, I mean, this is like a snapshot, a high yield kind of thing related to ADHD, right? Strong evidence for acute interference of cannabis on attention. There is mixed evidence for impairment in attention after cessation. So for having kind of like persistence impairments. It's kind of mixed. Some studies say they have seen that. Some are like, no, it should really improve after you've stopped using cannabis. And then very limited evidence, basically none, supporting cannabis use for ADHD. So in the book I referenced earlier that I've edited, we have a whole chapter on outpatient psychiatry and cannabis use. And one of the things we talk about is ADHD, and saying that cannabis use alone is not an absolute contraindication to treatment of ADHD with a stimulant, but it may warrant conditional prescribing practices. All right, so that's just me throwing a bone to those of us that do treat ADHD. Most inpatient CL psychiatrists do not. So 2 months later, Derek comes back to clinic, says, actually, I would like to stop using cannabis. In general, I think my things are going better when I'm not using it so heavily. So that's amazing. This does actually happen. I know some of you may be skeptical, but he does express his concern about his ability to do this, since he has struggled in the past, and asks if there's any way for him to be more successful or to help him be more successful, which is fabulous because, like I said, many patients fail because they try to do this cold turkey. So when it comes to medication-assisted treatment of cannabis use disorder and withdrawal, no medication has been formally approved by the FDA for the treatment of cannabis use disorder or withdrawal. That being said, there are a lot of medications that can be helpful. I talked about gabapentin already. Gabapentin can be helpful in the acute withdrawal period or for ongoing use as someone is tapering. This can be for a variety of things, right? It can help with the sort of pain, anxiety, sleep. And so in most of the clinical studies, they kind of show target doses of 300 BID plus 600 milligrams QPM. N-acetylcysteine NAC, I know we're looking at it for everything, but really it can be quite helpful for some patients for cravings specifically. So it's not really going to help with acute withdrawal, and that's like in terms of helping them physically feel better, but it can help with cravings. Might have more evidence in adolescents than adults, but I've certainly used it in adults who have said it was helpful. And usually we're using 1200 milligrams BID or targeting that. I already talked about dronabinol and Marinol. I mostly use this in the inpatient setting, but I am aware of cases where they've used it outpatient and found it helpful. It just might be harder to get approved. But certainly if you're working in inpatient CL or inpatient psych, this can be worth it if you have someone who like the timeline fits, they have the symptoms, they have the right use history, and they're having a lot of withdrawal symptoms that are pretty uncomfortable. Like I said, zolpidem has some evidence for specifically the prolonged insomnia part of withdrawal. And then mirtazapine can be great, right? Because it can help with sleep and appetite. Here's just a few more references in case you want to read more about this. Really what we found is like, generally most papers have not been supportive of using something like dronabinol to treat use disorder long-term. That a lot of the time it was not seen as helpful for someone to start decreasing use or abstaining. But people are interested, right? Because it's kind of like maintenance therapy, like what we do with nicotine. So that's where this idea came from. But definitely was found in most studies to be helpful in the short term, like particularly for the withdrawal part. So we're getting near the end. So a few high yield tidbits. So I've sort of said some of these already, but high potency forms of cannabis generally lack evidence for efficacy or benefit, but have lots of evidence for harm. So this is one of the things I will counsel on a bit more aggressively when it comes to cannabis use. Smoking and vaping cannabis carry specific health concerns, right, related to respiratory health. And lower risk formulations include oral and topical. I say lower risk with the asterisk because there is some evidence coming out that, when I talk about the cardiac effects and some of the psychiatric effects, that maybe that's not lower, but it's just for overall health in general. Fewer physical health effects from the oral and topical forms compared to smoking and vaping. If you have a patient that is using strains that include THC, you need to be aware of the impact on things like motor functioning, reflexes, and therefore impact on tasks like driving and operating heavy machinery. People ignore this, but our medications like opioids, benzodiazepines, right? They have warning labels about not using this while operating heavy machinery, and really the same applies to THC and those forms of cannabis. CBD predominant strains of cannabis are less risky for psychiatric comorbidities, at least with the information we have now. And infrequent and intermittent use is less risky than daily and multiple time per day use. And so in summary, right, cannabis is associated with a variety of neuropsychiatric effects like agitation, catatonia, delirium, cognitive changes, and psychosis. Use disorder and withdrawal is often under-recognized and undertreated, especially in acute medical settings. And so you need to consider medications and symptom support when needed or appropriate. It's really important for us to be aware of limitations of current evidence for and against cannabis, because headlines are misleading. Cannabis is neither all good nor all bad in most cases, but has kind of some nuanced risk. And so you need to consider the cannabis use in the context of the patient in front of you and the context of what we do and do not know. So when you're talking to your patient, this is going to go much better and be much more accepted if you acknowledge what areas the evidence is more gray or is like kind of rapidly evolving. It's okay to acknowledge when we do not have clear answers when it comes to cannabis. And it's really important to take a harm reduction and psychoeducation approach. And as part of that, understanding and identifying which symptoms they are self-treating with cannabis is sort of paramount. So this is what you need to do, because patients need care, and cannabis use should not be sort of a contraindication to care. But there certainly may be times where certain medications cannot be used or cannot be used right away because of cannabis use. And we need more high quality research. So that brings us to the end. I just wanted to kind of highlight a few things. A lot of things I talked about today came from these books. While I do not have any kind of required disclosures or kind of like relationships with ineligible companies, I do have chapters in these books, and I do have a royalties agreement with Springer Publishing for this book. So I just want to kind of highlight that because I do mention it a few times. Of course, I think it's great, but you should know that. And then, but these are all kind of great books that are available. And then this is something that's available for free if you're interested in trying to implement cannabis courses in your institution. I have a curriculum that's published on MedEd Portal and is totally free to download. Lastly, thank you so much for listening to this recording. If you have any other questions, please don't hesitate to reach out through the ACLP app. I will be physically at ACLP, but also I've included my email address, and I'm happy to kind of chat more. So thanks so much.